So the key point is that for the majority of patients, either Idelalisib or Ibrutinib results in a sustained duration of remission with continued administration. But there are a subset of patients who will either become intolerant of the drugs or who will progress during therapy, for whom the best option remains to be determined. So we're beginning to accrue some preliminary data suggesting that in the case of a kinase inhibitor failure, let's say, that a patient treated with Ibrutinib can be successfully salvaged with treatment with Idelalisib and vice versa. And there was an abstract presented by Dr. Mato and colleagues at ASH this past December that suggested that patients can achieve about a 50% response rate when they're treated with the alternative kinase inhibitor. In his presentation, as well as data I presented with an oral inhibitor of BCL2, that drug is called venetoclax, again, not yet approved, but that drug may achieve response rates that are very similar in a group of patients who are at high risk because of former kinase inhibitor failure. We showed that in both patients with previous treatment with Ibrutinib or immediate previous treatment with Idelalisib, response rates of 50 to 60% could be observed with a favorable toxicity profile. So there do appear to be options, but understanding how best to sequence these single agents is an important question going forward.
And that's still relapse setting, right?
Still relapse setting. For right now, only Ibrutinib has a frontline indication. Idelalisib, venetoclax, when it is approved, are all for relapse disease, at least for now.
And then finally, your last point.